Okay, let's unpack this. Nursing school is just a whirlwind of information, isn't it? You're absorbing so much, like from pathophysiology to patient care, and sometimes it honestly feels like trying to drink from a fire hose.
Oh, absolutely. It really does. And that's exactly why we're here today. To give you maybe a shortcut, a structured way to connect those dots, especially when it comes to the foundational elements of nursing practice. Think of this as your essential toolkit, before you even get to specific
That
diseases.
precisely, yeah. Today we're taking a deep dive into Section 1, Concepts in Nursing Practice. This is from Lewis's Medical Surgical Nursing, 12th edition. Our mission, basically to integrate these crucial chapters, show you how they build on each other, highlighting shared strategies, and really emphasizing the nursing process, critical thinking, collaborative care, all that good stuff.
Hmm.
This is about giving you those aha moments that make everything just click.
Exactly. We'll cover everything from what it means to be a professional nurse to those broad societal factors impacting health, the nitty-gritty of patient assessment, how we effectively teach and empower patients, and critical considerations for diverse and vulnerable populations. These aren't just isolated topics, they are the bedrock, the absolute foundation for providing truly holistic, patient-centered care.
Okay, let's kick things off with Chapter 1 then. Professional nursing. This really sets the stage for your entire career, laying out the core identity, the responsibilities of a nurse.
Indeed. It emphasizes that nursing is far more than just, compassion. It's a highly specialized profession, right at the forefront of patient care. We're talking about providing skilled care, advocating for rights, teaching, supporting caregivers, and navigating this incredibly complex healthcare system across all kinds of settings.
And it highlights how nursing has evolved
Right.
to meet society's needs, with different scopes of practice depending on your education, generalists, APRNs, even those with research doctorates.
And central to this are the ANA standards of professional nursing practice. These guide how nurses competently deliver care. They're based on the nursing process and behavioral competencies, practicing ethically, using evidence-based approaches. It's all in there.
Okay, here's where it gets really interesting for students, I think. The QSEN competencies. Quality and safety education for nurses. These 6 core abilities: patient-centered care, teamwork, safety, quality improvement, informatics, BBP. These aren't just buzzwords, are they? They're integral to safe, effective care.
Absolutely not just buzzwords. They shape everything. Think about clinical judgment. It's not about memorizing facts. It's about making sense of the information you have, identifying the priority problems, and generating solutions. Like those NCLEX-style questions, they challenge your decision-making, your judgment.
And the roadmap for that judgment is the nursing process,
Mm.
ADPIE or AAPI. Assessment, diagnosis or analysis, planning, implementation, evaluation, your systematic approach. We'll see this framework pop up again and again throughout the textbook.
Definitely. And you can't do any of this effectively without good communication. Teamwork hinges on it. The chapter highlights 2 key models. First, SBA.
SBAR, situation, background, assessment, recommendation.
Right. A structured way to communicate patient status. So, say you're calling a physician about new atrial fibrillation. You'd state the situation, the background, and then in the assessment part, you'd say something like, the atrial fibrillation started about 10 minutes ago. Heart rate's 124, BP 90 or 60. The patient is reporting dizziness. That's clear, structured assessment data.
Makes sense. And the other one?
CUS concerned, uncomfortable, safety. This is for escalating critical info quickly. Like if you're genuinely worried about a patient's worsening confusion and their breathing, using CUS signals that urgency clearly. Bump, I'm concerned, I'm uncomfortable, this is a safety issue.
Okay, crucial tools. Building on teamwork, there's delegation. Another core competency, understanding the 5 rights of delegation is key here because RNs delegate tasks but keep the accountability right.
Exactly. You retain accountability. So an LPN or VN might change a stable abdominal wound dressing, but the RN has to do that initial assessment. You can assign an LPN VN to give meds within their scope, but an assistive personnel, an AP, might handle vital signs or feeding assistance. It's about matching the task to the right scope and skill level, always considering patient stability.
Got it. Then there's safety, a huge focus.
Huge. Preventable medical errors are a serious problem. The National Quality Forum, NQF, defines serious reportable events, SREs. They're also called never events, like a patient getting a stage 3 pressure injury after admission. That shouldn't happen.
And the Joint Commission tracks sentinel events.
Yes, sentinel events signal the need for immediate investigation. Think wrong site surgery, major issues. And a critical nursing role is preventing failure to rescue, recognizing those subtle changes before a patient crashes.
Which leads naturally into quality improvement or QI.
Right. Systematic actions to monitor and improve care. The National Database of Nursing Quality Indicators, NDMQI, is important here. It tracks nursing-sensitive outcomes, things like fall rates, healthcare-associated infections. It shows how our nursing care directly impacts those numbers.
And informatics. It's more than just charting, isn't it?
Oh, much more. It's using technology, EHRs, telehealth, medication apps, CPOE to manage knowledge, reduce errors, support decisions, all while protecting patient privacy. IHUBA is paramount here.
Okay, last one from Chapter 1, Evidence-Based Practice, EVP.
A problem-solving approach, using the best available evidence, your clinical expertise, and the patient's preferences and values. The PICOT format helps frame clinical questions. Remember that example. In adult abdominal surgery patients, is splinting with a binder or a pillow better for reducing ambulation pain post-op day 1? PICOT helps you find and weigh the evidence to answer questions like that.
Okay, that's a solid foundation from Chapter 1. Now, Chapter 2 shifts gears a bit. It introduces social determinants of health, SDH, moving from the how of nursing to the why and where.
Exactly. This is so critical. It's recognizing that a patient's health isn't just about their biology. It's deeply tied to their life circumstances.
So, SDH are those non-medical factors affecting health outcomes. Where you're born, live, work, age, all that. It really grounds us in the real-world context of our patients.
Yes, and it's crucial for understanding health disparities, those differences in disease rates, mortality among specific groups. Our goal is health equity, making sure everyone has a fair shot at achieving their best health.
What are some key determinants mentioned?
Well, neighborhood and place is big. Housing quality, exposure to hazards, transport, access to healthy foods, safety. Think about rural areas often facing geographic barriers to care, higher rates of chronic disease. That's a place-based disparity.
And economic stability.
Absolutely. Wealth, education, employment, income, debt. Poverty limits access to so much healthy food, safe housing, healthcare itself.
Which ties into healthcare excess insurance, financial resources, even systemic barriers like clinics not having interpreters.
Education level matters too. Generally, higher education correlates with better health and health literacy.
Right. That impacts a patient's ability to manage conditions like diabetes or just understand medication labels. It's huge.
And don't forget, community social connections, support networks, community safety.
And woven through all of this is culture.
Yes. Culture isn't static, it's a dynamic way of life. Behaviors, beliefs, values, traditions. Our own values, often formed unconsciously, really influence how we judge other cultures. We have to be aware of that. And remember, there's huge diversity within any cultural group. Some use folk healers, others seek formal care. It varies.
Which brings us to cultural competence.
Your ability to understand, appreciate, and work effectively with people from diverse cultures, it has 4 parts. Cultural awareness, knowing your own biases. Cultural knowledge, learning about others. Cultural skill, adapting care. And cultural encounters, actual experience.
Like asking about the significance of a personal item a patient wears before a procedure. That's cultural skill.
Exactly. It shows respect and understanding.
So practically, how do nurses manage this?
Start with self-assessment.
Yeah.
Understand your own cultural background and potential biases. Then conduct a cultural assessment with your patient. Understand their beliefs, practices, communication style, eye contact, touch, gender roles, and how they make decisions. And advocate. Advocate for better healthcare access, and always use qualified medical interpreters, not family members. That's crucial for accuracy and privacy.
Okay, moving from that broad context right into hands-on skills. Chapter 3, Health History and Physical Examination. This is where assessment skills really come into play, the first step of the nursing process, and it's continuous.
Right. Your nursing assessment contributes to that comprehensive database. It combines the nursing history, the physical exam findings, medical records. This data is absolutely critical for making clinical judgments and establishing those baselines we need to track changes.
And it's about gathering both subjective data, what the patient tells you, their symptoms,
Like, I am so short of breath.
and objective data, what you observe and measure, their signs.
Like, their respiratory rate is 30 and their O2 sat is 88%. Objective signs.
And during the interview, trust and respect are key, remembering those cultural influences on communication from Chapter 2.
Absolutely. Eye contact, personal space, modesty, touching it all matters and varies culturally.
How do we organize all the history information?
Gordon's Functional Health Patterns. It's a systematic framework, covers 11 areas, like health, perception, health management, nutritional metabolic, activity exercise, value belief patterns. It helps you get a holistic view, identify strengths, problems, and risks.
And the physical exam techniques.
The classics.
Yep. Inspection, careful observation. Palpation using touch. Assessing masses, pulses, tenderness, even temperature, like using the back of your hand for skin temp, fingertips for pulses.
Some percussion.
Tapping the skin. You listen for sounds. Resonant over healthy lungs, tympany over air-filled areas like the gut, dull over dense organs like the liver, flat over bone or muscle.
And auscultation.
Listening with your stethoscope. Breath sounds, bowel sounds, heart sounds. Each technique gives you different objective clues. And we don't always do the same type of assessment, do we?
No, you adapt. An emergency assessment is rapid, focused on ABC's airway, breathing, circulation, disability, life-threatening situations. A comprehensive assessment is the detailed head-to-toe, usually on admission. And a focused assessment zeroes in on a specific problem, like an abdominal assessment just for pain or listening to lungs for suspected pneumonia.
What about assessing older adults?
Yeah.
Any key differences?
Definitely adapt your technique. Ensure comfort, warmth. They might have sensory issues, so check for glasses, hearing aids. Their abdominal wall might be thinner, making organs easier to palpate. But also be aware they might underreport symptoms.
Attributing things to just getting older.
Exactly, which could mask something serious, so you need to probe gently.
Okay, building right on assessment comes Chapter 4, Patient and Caregiver Teaching, Empowering Patients.
Yes, a core nursing intervention. This is where knowledge becomes power for the patient and their family.
And it's an RN responsibility, right?
Yeah.
Can't delegate this.
Cannot delegate teaching. It's fundamental to quality care. Every interaction counts: formal sessions, informal moments when giving meds. The goals are broad: promoting health, preventing disease, managing illness, making good treatment choices, especially vital for chronic conditions, helping patients self-manage and prevent complications.
And it follows a process, like nursing.
Just like it. Assessment: are they ready to learn? Identifying needs, setting goals, implementing the teaching, and crucial, evaluating if they understood. Remember adult learning principles. Adults need to know why they're learning. They like self-direction, learn best when ready, and build on experience.
And motivational interviewing comes up again here.
Yes, that non-confrontational approach to encourage behavior change. Patients move through stages. Pre-contemplation, not thinking about change. Maybe a smoker who says, "It doesn't bother me." Your role: gently raise awareness of risks.
Contemplation.
Thinking about it, but ambivalent. I know I should quit smoking, but you help weigh pros and cons, build their confidence. Then comes preparation, action, maintenance, termination. Each needs ongoing support.
And involving caregivers seems critical.
Absolutely crucial. Patients might be too sick or stressed to absorb everything. Assess the caregiver's needs, their stress level, risk for burnout. They need support too.
What about challenges? Lack of time, maybe.
Lack of time, nurse-patient goal differences, early discharge. These are real challenges. Solutions involve prioritizing, breaking info into small chunks, reinforcing frequently, use those teachable moments, and leverage things like TJC's Speak Up initiative or Ask Me 3. Encourage patients to ask, what's my main problem? What do I need to do? Why is it important?
What factors affect someone's ability to learn?
Several. Physical things like pain, fatigue, meds, especially opioids, can impair learning. Teach when pain is managed. Psychologic factors too. Mild anxiety can actually help focus, but moderate or severe anxiety shuts learning down. Depression impacts readiness. Defense mechanisms like denial.
And sociocultural factors.
Yep.
Health literacy.
Huge. Health literacy, the ability to understand health info, is a barrier for most U.S. adults, like 90%. So use plain language. Aim for maybe a 5th grade reading level in materials. Use the teach-back method. Teach in small bits. Cultural beliefs, values, who makes decisions in the family, all influence teaching.
What are some good teaching strategies?
Individual teaching, small groups, lectures combined with discussion. And for skills like insulin shots, demonstration, return demonstration is key. Show them, then have them show you, sometimes called show back. Use visuals, printouts, tech, but always check if they're accurate and easy to understand. Adapt for disabilities, large print, etc.
And evaluation. How do you know they really got it?
Teach back. It's the gold standard. Don't ask, do you understand? Ask, can you tell me in your own words how often you need to change this dressing? Or show me how you would use the inhaler. Involve caregivers in the teach back too. That confirms understanding.
Great. Now let's apply all this. Chapter 5, Chronic Illness and Older Adults. A huge part of nursing care.
Definitely. Chronic illnesses are long-term, rarely cured, involve irreversible changes, maybe disability. They cause 70% of U.S. deaths. And many older adults live with multiple chronic conditions or multimorbidity. The chapter points to things like Not enough physical activity, poor diet as contributing factors.
And it's not always a steady decline, is it? The chronic illness trajectory model.
Right. It describes phases, onset, stable, acute exacerbation, crisis, comeback, unstable, downward trend, dying. So managing chronic illness means preventing those crises, sticking to treatment, controlling symptoms, adapting life. It's a journey.
The chapter also breaks down prevention levels again.
Yes, primary, preventing disease altogether, diet, exercise, vaccines like flu or pneumococcal. Secondary, early detection cancer screenings, blood pressure checks. Tertiary, limiting disease progression after it started, rehab after a heart attack or stroke.
In demographics, older adults are the fastest growing group, increasingly diverse. We need to combat ageism.
Absolutely. Ageism, negative attitudes leading to discrimination is harmful. We have to challenge it. Frail older adults are a specific concern. At risk for decline, malnutrition.
The scales tool for malnutrition.
Yes, scales, sadness, cholesterol low, albumin low, loss or gain of weight, eating problems, shopping food prep issues, good mnemonic. They're also at risk for dehydration, falls, cognitive issues.
And caregiver support is huge here too.
Vital. Recognize caregiver stress, burnout, isolation. Encourage self-care. Suggest support groups or respite care. We also have to be aware of elder mistreatment, EM. It's often hidden, underreported. Physical, psychological, financial abuse, neglect.
And self-neglect is the most common type referred.
Sadly, yes. Self-neglect is what Adult Protective Services sees most often.
What about resources?
Know about home health care and PACE programs for all-inclusive care for the elderly. PACE is great, offers comprehensive care for eligible folks 55 plus weight. And the 4M model is a great framework for age-friendly care.
Right, the 4 MINs. What matters patient goals? Medication keeping it appropriate lowest dose. Mentation checking for dementia, delirium, depression, and mobility maintaining function.
It helps focus care on what's really important for the older adult.
Legal and ethical issues come up a lot too. Advanced directives.
Crucial. Healthcare proxy, living will. These document wishes for end-of-life care. Nurses are often right there, dealing with ethical dilemmas around decision-making capacity. It's complex.
And gerontologic nursing itself requires special skills, doesn't it? Because of underreporting and that cascade effect.
Exactly. That cascade disease pattern. Insomnia leads to sleeping pills, leads to lethargy, leads to a fall, hip fracture, pneumonia. One thing triggers another. Communication needs to be simple, direct. Use eye contact appropriately. Maybe gentle humor. Prioritize comfort. During assessment, use their glasses, hearing aids, check for fatigue, allow plenty of time, and always assess fall risk history, meds, environment.
Medication use in older adults is tricky too. Pharmacokinetics change.
Right. Absorption, distribution, metabolism, excretion, all change with age. Higher risk for drug toxicity, adverse events. The AGS Beers criteria list, potentially inappropriate medications for older adults. It's a key resource nurses should know.
And restraints.
Last resort, only for immediate safety of the patient or others. Requires assessment, trying alternatives first, low beds, alarms, and an HCP order. They are not for fall prevention or staff convenience, period.
Okay, final chapter in this section, chapter 6. Caring for LGBTQ plus patients. Really bringing inclusion to the forefront.
Yes, and it emphasizes the health disparities this community faces and the absolute need for unconditional, inclusive, respectful care from nurses. And like you said, getting the language right is the first step.
So key terms: biologic sex assigned at birth, intersex for variations.
Right. Gender identity, how someone perceives their own gender. Cisgender if it aligns with assigned sex. Transgender if it differs. Avoid transsexual.
And gender itself is seen as socially constructed, with variations across cultures.
Exactly, like two-spirit in some indigenous cultures. Then, sexual orientation attraction, behavior, attraction, identity. Use terms like gay, lesbian, bisexual, avoid homosexual, and definitely avoid sexual preference. Orientation isn't a preference.
Terms to avoid also include it for a person, or asking for a trans person's real name.
Please avoid those. It's deeply disrespectful. This matters because LGBTQ plus folks experience higher rates of substance use, depression, anxiety, violence, often due to minority stress. And a big barrier is often lack of training for healthcare providers in culturally appropriate care for this community.
What about older LGBTQ plus adults?
Unique challenges. Often lack kids for support, rely on partners or chosen family. Many live through the height of the HIV epidemic, and some fear discrimination in long-term care, so they might hide their identity, go back in the closet.
How can we create inclusive environments then? TJC has guidelines.
Yes. Post non-discrimination policies. Have unisex bathrooms available. Use inclusive intake forms. Ask sexual orientation and gender identity. Maybe display rainbow flags, offer LGBTQ plus literature. Small things can signal safety and inclusion.
And communication strategies.
Always ask and use the patient's preferred name and pronouns. Is there a name you'd like us to use? If you mess up a pronoun, just apologize quickly and correct yourself. Move on. Use that two-step gender question, sex assigned at birth, and current gender identity. Avoid gendered terms like sir or ma'am until you know their identity. Just how may I help you? Works fine.
Recognizing family of choice.
Crucial. For many LGBTQ plus people, chosen family is their primary support. Strongly counsel them on advance directives, especially if not legally married, so their chosen person can make decisions and visit.
And the health history needs to be non-judgmental.
Absolutely. Understand why you're asking certain questions. Remember, screening needs lesbian and bi women still need pap tests and mammograms. And for trans individuals, don't make assumptions about surgery. A transgender woman might still have a prostate and need screening. A transgender man might still need cervical cancer screening if they have a cervix.
What about gender-affirming care specifically?
It's a spectrum. Includes gender-affirming hormone therapy, GAHT, testosterone for masculinizing effects, estrogen anti-androgens for feminizing. Nurses teach injection techniques, warn about topical hormone transfer risk. There are also non-surgical things like fillers, vocal therapy, and gender-affirming surgery, GAS chest procedures, genital surgeries, etc.
But not everyone wants or needs surgery.
Correct. Not all trans people seek surgery. If they do, pre-op involves confirming persistent gender dysphoria, informed consent, stable health. Post-op care is standard, post-op plus specifics, drain care, pain management, teaching activity limits, like no heavy lifting after top surgery. It's comprehensive care tailored to their journey.
Wow, okay. That brings us through section 1. So, wrapping this up, what does this all mean for you, the student listener, moving forward?
It means Section 1 isn't just a set of introductory chapters. It's really the lens, the foundation for all the patient care you'll provide later.
Exactly. We've seen how being a professional nurse, understanding SDH, mastering assessment, teaching effectively, caring for older adults, providing inclusive LGBTQ plus care, it's all interconnected. These foundational concepts are crucial for holistic, patient-centered care. It underscores that nursing is about the whole person, right, in their unique context.
Absolutely. Which leads to a question for you, the learner. As you take in these concepts, think about your responsibility. How will you apply this knowledge not just to one patient, but contribute to making healthcare systems truly equitable, safe, and individualized for everyone?
How will you weave these principles, professionalism, context, assessment, teaching, inclusivity, into every single patient interaction? Think about it. Each patient is unique. These early chapters give you the essential pieces to start putting that picture together. Keep digging, keep asking questions, keep learning. Your patients will thank you for it.